So this is the first video on the respiratory system, and the main function of the respiratory system is to carry out gas exchange. Now there are four main components of this that we're going to examine. One is moving air into and out of the lungs, and that's what this PowerPoint and video are going to be concerned with. Pulmonary gas exchange, gas transport in the bloodstream, and peripheral gas exchange, and those three things will be covered in the second video. So let's talk about the anatomy of the respiratory system. First of all, you can talk about it structurally, in which you divide the respiratory system into the upper respiratory system, which is structure superior to the larynx, and the lower respiratory system, which of course is going to be the larynx, the trachea and its branches, and the lungs. You can also divide the respiratory system into functional areas. One is going to be the conducting zone, and these are going to be the tubes that warm and moisten and take air to the respiratory surfaces. So this is basically going to be the structure superior to the larynx, the trachea, and its branches. Then there's the respiratory zone, which is where actual gas exchange occurs. So you can have the upper and lower respiratory system, and you can have the conducting and the respiratory zones. So taking a look at the upper respiratory system, there are a number of things that I want to bring to your attention. First of all, that you have on the right the nasal conchae, the superior, the middle, and the inferior nasal conchae. And these are going to be structures that actually warm and moisten the air as it passes from the external nares on the right through the internal nares on the left. To the back of the internal nares, you're going to find the nasopharynx. This is the portion of the pharynx that is posterior to the nasal cavity. So inferior to that, you have the oropharynx, which is the portion of the pharynx that is behind the mouth. Inferior to that, you're going to have the laryngopharynx, which is the portion of the pharynx that is posterior to the larynx. Okay, as far as the larynx itself goes, you have what are called ventricular folds. These are otherwise known as false vocal cords, and then the vocal folds themselves, which are called the true vocal cords, and these are both contained in the larynx. The larynx is going to be the top portion of the trachea, which most people know as the windpipe. Okay, so taking a look at the larynx itself, there are going to be three major cartilages that I'm going to draw your attention to. So the first thing to tell you is that its structure is made up of cartilage, and there are ligaments that are going to attach the separate cartilages. So the thyroid cartilage, located right here, let's see, let me turn that on, located right here, is your largest cartilage. So you can see that it's very large. The cricoid cartilage has an attachment both to the thyroid cartilage and to the trachea itself. So these would be the tracheal cartilages, and this would be the cricoid cartilage. Now there are ligaments that attach all of these. So the cricothyroid ligament is going to attach these two largest cartilages, and the cricotracheal ligament is going to connect the cricoid cartilage with the trachea. Okay, the third cartilage that I want to bring to your attention is the arytenoid cartilage, which is right here. And the reason why I want to do that is because the arytenoid cartilage is connected to the corniculate cartilage right here, and it's the corniculate cartilage that actually pulls on the vocal cords and actually allows them to be tightened, and that's going to make a difference in the pitch of your voice. There was one other thing that I want to mention to you right here, and it's that the tracheal cartilages don't make it all the way back around to the posterior portion of the larynx, and so there's a little bit of actually smooth muscle at the back of the larynx, and there's a good reason for this. It's because your trachea is actually anterior to your esophagus. When you swallow food and it goes down your esophagus, it's going to bulge out a little bit, and that means that the back of the trachea has to have a little bit of give to it. So these cartilages don't go all the way around the trachea. Instead, they just go most of the way around the trachea, and they're C-shaped instead of true rings. Okay, and again, the arytenoid cartilage is what has your attachment to the vocal cords and can pull on them. All right, now the larynx itself has the vocal cords, and these are elastic ligaments. And what you can see when you have the movement of vocal folds apart, this is abduction. When they move together, it's adduction. So these are going to move back and forth. So they are attached to the arytenoid cartilages. there are muscles that move the cartilages and therefore stretch the vocal cords. And the amount of stretch determines pitch. So if you ever tuned a guitar, you know that to make a guitar string go higher, then you're actually increasing the tension on the string, stretching it out that much more, and that makes it higher. When you loosen the string, the pitch drops. So when you tighten the vocal cords, they actually will vibrate faster, and that gives you a higher tone or higher pitch. And so if I tried to keep my vocal cords at the same length and not stretch them out anymore, I'm speaking in a monotone. So I'm sure you're glad that I don't do that. I like to change the pitch in my voice for emphasis and things like that. That is a part of nonverbal communication. So the velocity of air through the larynx is what determines the volume. And so it's actually the compression of your abdominal muscles and the movement of your diaphragm that can cause air to move through the larynx faster, and that's going to determine volume. So given that the faster that these vocal cords vibrate, that the faster they are, the higher the pitch goes, I want you to think about what happens when you get a cold and your voice really drops. And so when I get a cold, I do my best to say, Luke, I'm your father, at least 5 or 6 different times, because I've got a deep enough voice at that point to pull it off. When you've got any kind of mucus coating on your vocal cords, it's going to really slow the vibration down. It's going to drop drop the pitch of your voice. Okay, so the trachea is otherwise known as the windpipe, and as I mentioned before, the tracheal cartilages are C-shaped, and so they're not a complete ring around. So here you see this sort of yellow, this yellowish colored cartilage stopping. Okay, and so at the back side or at the posterior side, you've got what's called the trachealis muscle, which is going to be right here. So as I said, it's going to be smooth muscle. Okay, so these tracheal rings get connected to one another by the annular ligaments. So that's going to be right here, and you can see that they are in between these cartilaginous rings. Okay, the trachealis muscle, again, it's smooth muscle, and when it contracts, it can narrow the diameter of the trachea, but it can also give you, a little bit of give if food is passing through the esophagus directly behind it. So again, right here on the diagram, you can see that the esophagus is right here behind the trachea. Okay, now the carina is located right here. It's basically where the trachea divides into the left primary bronchus and the right primary bronchus. And so the carina is actually your last tracheal cartilage. Again, it's located at the split between the left and the right main stem bronchi. So as with so many other things with A and P, you've got multiple names for the same thing. Primary bronchus and main stem bronchus are the same thing. And its mucous membrane here is one of the most sensitive areas for triggering a cough. So you can get something really small down in there, and it'll cause you to cough like crazy. So I can actually remember being reminded of this by walking through a cloud of fruit flies. Got one of those tiny little fruit flies down in that area, and I couldn't stop coughing because it was that sensitive. Just a little fruit fly triggered it that much. Okay. So let's talk about the lower respiratory system. And to talk about that, we've got to talk about the bronchial tree. So the trachea divides into the right and left primary bronchi, and these will branch into smaller and smaller airways that end in terminal bronchioles. So these will enter at the hilum of the lung. So the hilum of the lung, it's not really well pictured here, but it's going to be this point right back here where the bronchi actually enter the lung. And you're also going to see blood vessels entering and leaving the lung, and nervous supply entering and leaving the lung at the hilum. So as I said, entry site for primary bronchi, blood vessels, nerves, and the one thing I forgot to mention was the lymphatics. Okay, now the primary bronchi are also called main stem bronchi, and that first split is called the first generation. And so again, a generation is a division into smaller branches. So the primary bronchi are still incomplete rings of hyaline cartilage. I'm sorry, that may have faded out. They're incomplete rings of hyaline cartilage. The secondary bronchi are called lobar bronchi because there's a bronchus for each lobe. Now, if you look at the right lung, remember that when you're looking at this diagram, this person is facing you. So their left lung will be on your right and vice versa. So the right lung has got 3 lobes. The left lung has got 2 lobes. And the reason why the left lung has got 2 lobes is this. I want you to look at this sort of notch right here. This is where the heart kind of fits into because the heart is off center. So you're going to have 2 lobar bronchi on the left, 3 lobar bronchi on the right. Okay, this is your second generation. Now the tertiary bronchi are called segmental bronchi, so they're going to go into different segments of these lobes. There are 10 on the right and between 8 to 10 on the left, and again that smaller number is because of that cardiac notch. This is the third generation, and there are 9 to 12 different generations of bronchial branch division, and 23 to 25 generations overall. So this includes bronchi and bronchioles and alveolar structures. So that's a lot of generations, and it means that you can go from the trachea, which is really large, down to really microscopic structures with these alveolar structures. Okay, so as you move down the tree, the amount of cartilage in the walls of the tubes will decrease, and you'll have, first of all, plates of cartilage replacing the incomplete cartilage rings, and then at your most distal and your smallest bronchioles, you have a complete disappearance of cartilage, and so those walls are going to be all smooth muscle. So smooth muscle, the proportion of that increases as you go down, as you move down the tree, as you go from generation to generation. And so it's going to enclose or encircle the lumen in spiral bands. Now, your clinical implication here is that in obstructive airway diseases such as asthma and COPD, when this smooth muscle contracts, instead of limiting the amount of air that passes through, it may completely shut off the amount of air that comes through. Okay, so let's take a look at the bronchiole level. So the bronchioles are less than 1 millimeter in diameter. They've got very minimal cartilage, and they've got an increased amount of smooth muscle. Now, one thing that I want to make clear here is that the smooth muscle is not continuous. So you've got sort of strips, as you can see right here in this diagram. You've got strips of smooth muscle instead of a continuous sheath of smooth muscle. Okay, now these can constrict to a greater degree than other portions of the conducting zone. And the reason why they can constrict to a greater degree is because they don't have to bend any type of cartilage. You've just got the smooth muscle with the layers of the bronchiole within them. Okay, now the terminal bronchioles are your very last portion of the conducting airways. And air will move from these into the respiratory portion of the airways. Now there is something else that I wanted to mention here. I wanted to show you a picture of an asthmatic bronchiole so that you could see a number of things about it. For one thing, the muscle layer is a little bit thicker. You have an overproduction of mucus within the bronchiole. And so when you have that constriction, you stand a much greater chance of narrowing down on the bronchiole. Now, again, right here, you'll notice that the smooth muscle in this asthmatic bronchiole has contracted. So you can see that sort of squeezing occurring. And so again, when you have an asthmatic attack and these smooth muscle cells clamp down, it's going to make passage of air through those bronchioles a lot more difficult. Okay, so finally getting down to our respiratory surfaces. You have terminal bronchioles that branch into respiratory bronchioles. So there's a terminal bronchiole here, and you can see that it's branching into respiratory bronchioles. So the respiratory bronchioles lead into alveolar ducts, and here's a picture of an alveolar duct right here. So you can see that there's no smooth muscle that's surrounding it. That's how you can tell the difference between an alveolar duct and a respiratory bronchiole under a microscope. Absence of smooth muscle. And so basically an alveolar duct is going to be sort of a tube from which alveoli branch out. Okay. They are actually sites of gas exchange. Respiratory bronchioles are. That's the reason why they get called respiratory. So along with them, the alveolar ducts, the alveolar sacs, and the alveoli are sites of gas exchange. So what is an alveolar sac? It's basically a cluster of alveoli sort of surrounding a central area. That's what you're going to call an overall alveolar sac, and you can see the individual alveoli here, say here, and here, and I'm not going to try to draw too much more with this mouse because we all know how bad I am at it by now. Okay, so the alveolar ducts, again, they're surrounded by a lot of alveolar sacs and alveoli, and an alveolar sac is just two or more alveoli that share a common opening. Now you've got 300 to 400 million alveoli in each lung. And so what is an alveolus? It's sort of this cup or sphere-shaped pouch of simple squamous epithelium that gets supported by a really thin elastic basement membrane. Now it's important that the basement membrane be thin so that gases can diffuse through it, and it's also very important that it be elastic so that it can both expand and return to its original size. Okay, so the lungs themselves superiorly actually extend to just above the clavicles, which is a real surprise for a lot of people. You wouldn't think that your lungs actually come up that high, but they do. At the top of them, this is the apex, sometimes called the cupola. Inferiorly, they rest on the diaphragm, so they pretty much have a physical connection with the diaphragm. And the bottom of the lungs is called the base. And so these areas are opposite to the apex and the base of the heart. Remember, at the heart, the apex was inferior, the base was superior. In this case, the apex is superior and the base is inferior. Okay, the costal surfaces are the surfaces that have they don't have a direct tissue connection with the ribs. You'll see what I mean in just a little bit. So they don't have a direct connection, but they do have sort of a hydrostatic connection with the costal surface. Okay, so this is the surface that is closest to the ribs. And then finally, there's the mediastinal surface, which is medial, and this is the area where the hilum of each lung is located. And so hopefully you can see here in the hilum that you've got blood vessels, and you've got lymphatics, and you've got nerves that are coming in at this hilum. Okay, the left lung has a superior lobe and an inferior lobe and one fissure, which is the oblique fissure. And so if you look to the very right, you're going to see that oblique fissure running in this direction. So it's diagonal, therefore oblique. The right lung has got three lobes, a superior lobe, a middle lobe, and inferior lobe, and it's got two fissures. One is going to be oblique, and one is going to be horizontal. I don't know why they don't call it transverse. That would seem to make sense, but it's called horizontal. Okay, now that we're down to the respiratory tissue, we're going to take a look at the cell types that are in the lungs. So the first one that I want to talk about is pneumocytes. And these are two cells that actually make up the alveolar wall, type 1 and type 2 pneumocytes. Now the type 1 pneumocytes are the kind of faint cells right here. So they're all of these cells here that look very much like the simple squamous epithelium that you saw in lab at the beginning of this semester. So these are the cells that line the alveoli, and the reason why they're suited for diffusion is because they're very thin. It's a small distance for oxygen and CO2 to diffuse across. The type 2 pneumocytes, you can see, they're also called septal cells, and you can see them located. Here's an example of one right here. So that's going to be a type 2 pneumocyte. Now their job is to secrete alveolar fluid that contains a surfactant, and we'll get into what a surfactant is in just a little bit. Well, how about now? So it decreases surface tension in the alveoli. So surface tension is basically the attraction of water molecules to one another. And so these water molecules are trying to come together, and as they come together, they tend to collapse structures. If you blow a soap bubble, the reason why they pop is because surface tension draws the water in the soap bubble together. And so if the alveoli are left without any surfactant, then they will tend to collapse. And so the surfactant decreases surface tension and keeps the alveoli from collapsing. Now there has to be a little bit of surface tension there. You can't eliminate it entirely, reasons for which I'll get into later. But surfactant does keep them from collapsing. Now one of the reasons why premature babies have to be placed on a respirator is because their type 2 pneumocytes don't get really cranked up with the surfactant until very, very late in pregnancy. Okay, another type of cell, these don't make up the alveolar wall, but there are macrophages or dust cells, and their name kind of implies what they do. They go around in dust. They try to clean up debris from the type 1 pneumocytes. And so they're going to ingest debris. And finally, You've got fibroblasts, which are not pictured here, but these fibroblasts produce reticular and elastic fibers. So lung tissue is extremely elastic, and so the fibroblasts produce the elastic fibers that give lung tissue its elasticity. Okay, so if we take a look at a second diagram here, there are some things that I want to point out to you here. First of all, your type 1 pneumocytes are going to be basically like this one. So, oh crud, it's not working right now. Hang on. It's going to be basically like this one. Let's draw it in yellow so it shows up. So there's a type 1 pneumocyte. Okay, and here's a type 2 pneumocyte that produces surfactant. All right. Now, if we take a look at this is kind of a side view of one of these type 2 pneumocytes. And if we blow it out to right here, you can see this is actually the cell membranes of that simple squamous epithelial cell. So it's very thin. Here's the nucleus of that cell. And so you get a very thin membrane here. The capillary wall here are the capillaries that line the alveoli. Those capillary walls are also very thin. And this is your basement membrane here to here, which is also thin. So in order for oxygen to be loaded onto a red blood cell, it has to cross the type 1 pneumocyte membrane. It has to get through the basement membrane. It has to get through the capillary membrane. Then it has to dissolve into the blood plasma, and then it has to cross the red blood cell membrane in order to get in there. And so oxygen doesn't like to dissolve into watery environments very well, and so you'd better have some thin membranes to facilitate its crossing. Okay, so the cell types change in the bronchial tree. The epithelium will actually change. And so in the trachea, you're going to have pseudostratified ciliated columnar epithelium. And this is going to be in the trachea, in the primary, in the secondary, and the tertiary bronchi. As you move down further generations, you're going to have ciliated simple columnar epithelium that has goblet cells. So again, there's still going to be mucus produced, it's still going to be ciliated, but your type of cell changes. So this is in the larger bronchioles. Further down, you've got ciliated simple cuboidal epithelium, and you're going to find this in smaller bronchioles. And finally, at your smallest bronchioles, you're going to find non-ciliated simple cuboidal epithelium. This is in your terminal bronchioles. Okay, now we're going to get into pulmonary physiology. Okay, so pulmonary respiration involves gas exchange, and there are three processes in gas exchange. One is ventilation, which is the process of getting air in and out of the lungs, so airflow during inhalation and exhalation. The second is external respiration, where you have exchange of oxygen and CO2 at the alveoli in the lungs. And the third is internal respiration, where you have the exchange of oxygen and carbon dioxide at the tissue level. So this is after the blood transports the oxygenated red blood cells to the tissues. And so again, in this video, we're going to be examining ventilation, and in the next video, we'll look at external and internal respiration. So the first thing we've got to talk about with respect to ventilation is that this is the pressure in the thoracic cavity. Why do I have a picture of the planet here? It's because the pressure of the thoracic cavity is always described relative to atmospheric pressure. So atmospheric pressure is the pressure that is exerted by the air surrounding the body. And that's the reason, again, why I've got this picture in here. So air pressure is going to be bearing down on us. Okay, and this value is about 760 millibars, which is kind of a funny way of saying mmHg, but it's a whole lot less awkward. So if you've got a pressure that's less than, that should be atmospheric, not atmospheric. If you have a pressure in the thoracic cavity that's less than atmospheric pressure, say 759 or 758, it's going to be expressed as a negative number. If it's higher than atmospheric pressure, it's going to be expressed as a positive number. So again, everything is compared to atmospheric pressure because these pressure changes are going to actually be pretty small. If you're equal to atmospheric pressure, if the pressure inside the thoracic cavity is equal to the atmospheric pressure, then it's going to be zero pressure. Okay, So let's take a look at this. So we're going to look at a number of different types of pressure. The first is going to be intrapulmonary pressure. So taking a look at that intrapulmonary pressure, you can see the value right here. So intrapulmonary pressure is going to be the pressure that's within the lungs themselves. So this sometimes also gets called intraalveolar pressure. So again, pressure within the lungs inside the alveoli. Now, it's not going to remain at 760. This pressure is going to rise and fall with the phases of breathing, and we'll go into that in just a little bit. But it always does equalize with atmospheric pressure. So even if you change the intrapulmonary pressure up or down, then as air moves in or out in response to those changes, it's going to equalize at 760 with atmospheric pressure. Okay, intrapleural pressure is right here. So the intrapleural pressure is the pressure that's in between the visceral pleura and the parietal pleura. Remember, this is the pleural cavity that we're talking about, and the pleural cavity is this cavity that is made up of a double layered membrane. So the intrapleural pressure is the pressure in between the parietal pleura, which is the outer one, and the visceral pleura, which is the inner one. So again, outside of the alveoli, but not the chest cavity, or not the chest wall itself. Now this will always fluctuate with phases of breathing as well, but it is consistently 4 millibars less than intrapulmonary pressure. So you see here with this diagram that your intrapulmonary pressure is at 760 millibars and your interpleural pressure is at 756 millibars. So if you were to drop your intrapulmonary pressure to 759, you would see a corresponding drop to 755 of the interpleural pressure. Okay, transpulmonary pressure is going to be your difference between intrapulmonary and intrapleural. And so the size of this transpulmonary pressure will determine the size of the lungs at any time. So I said that if you reduce your intrapulmonary pressure from 760 to 759, you would see a corresponding drop in transpulmonary from 756 to 755, but there's going to be a little bit of a lag there. So if you drop the pressure inside the lungs, you drop the pressure inside the pleural cavity, but it's going to take a little bit longer, not exactly a second, but it'll take a little bit longer for that pleural cavity pressure to follow the pressure change from the intrapleural pressure. So the greater the transpulmonary pressure, the larger that the lungs are going to be. And the reason why is because if this intrapleural pressure drops, it makes a difference in pressure between the pleura and the lungs, and it kind of sucks the lungs out towards the pleural cavity. And this pressure also keeps the air spaces of the lungs open. So if there's a pressure, a little bit, what's called a partial vacuum, if you've got a smaller pressure in one place than another, it's called a partial vacuum. So if you've got a partial vacuum that surrounds the lungs, it'll always be drawn out towards that, and that does keep the lungs from collapsing. Now, if you have a puncture injury that goes through the pleural cavity, you can disrupt this pressure. So you might have the pleural cavity pressure equalize with the outside atmosphere, and it would no longer be less than the pressure inside the lungs, and that can lead to a collapse of the lungs. Okay, so taking a look at this, there are two forces that act to make the lungs smaller, which pulls the lungs and the visceral pleura away from the thoracic wall. So one thing that causes the lungs to become smaller is that the lungs are elastic, and they're going to basically shrink down the same way that an elastic strip would shrink down. And the second thing is that the surface tension of the alveolar fluid helps keep the lungs a little bit smaller. And so I said that you would not want to completely get rid of surfactant, or you wouldn't want surfactant to completely get rid of surface tension. And the reason why is this surface tension allows your lungs to compress, or helps the lungs compress when you're exhaling. Okay, so a force that opposes the elastic recoil of the lungs is actually the elasticity of the thoracic wall. So you can see here that the lungs themselves, the lung tissue will try to make the lungs smaller. The elasticity of the thoracic wall will try to make the whole thing larger. So the thoracic wall pulls the elasticity of it pulls it outward and enlarges the lungs. Now the pleural fluid actually holds the visceral and parietal fluid together by staying at a constant volume. So basically, let's say that the thoracic wall is moving outwards. What that's going to do is that's going to momentarily drop the pressure here in the pleural cavity, and then that's going to drag the lungs themselves outward. So there's something that's called mechanical coupling that means that when the thoracic wall moves upward and outward, it's going to drag the pleural cavity along with it, and the pleural cavity will drop in pressure. So it'll momentarily expand the pleural cavity, and that will create a little bit more of a lower pressure, a little bit more of a partial vacuum, which will drag the lung tissue out along with it. And so an example of mechanical coupling that I'm sure you're familiar with is you set a glass down on a napkin or on, say a cheap plastic coaster, and then you pick the glass up and the coaster or the napkin comes along with it. It's because there's this thin film of water between the glass and the coaster, and when you pick that glass up, it momentarily kind of stretches out that little bit of water and it creates a little partial vacuum. And so when you pick up the glass and create that little partial vacuum in the water, it sucks the coaster up along with it. And so if your lungs are moving outwards, then you get a little bit of a decrease in the pressure in that pleural cavity, and that sucks the lungs outward. Now, let's say that you're doing just the opposite and you're exhaling. And so if you have the lung tissue recoiling, as the lung tissue recoils and comes back inwards, it's going to drag that pleural cavity inwards, creates a little bit of a partial vacuum, which drags the chest wall in along with it. And so this mechanical coupling means that there's sort of a liquid coupling, which is the pleural cavity, between the lung tissue and the chest wall itself. Now, any sort of excess fluid will be drained by the lymphatic system because it's extremely important to keep the pleural fluid at a constant volume. So the net result of all of these forces is a negative intrapleural pressure. Okay, so let's talk about something else when it comes to the lungs. So there's a law in physics called Boyle's law, which says that volume changes can lead to pressure changes. So these pressure changes will lead to the flow of gases until you equalize those pressures. So I want you to look at the diagram to the right. Look at that upper diagram. When you depress that plunger, then the portion of that syringe here, of this area here getting smaller, is going to increase the pressure as you increase the volume. So you're going to see your pressure needle kind of move in this direction. Okay. Now, if from here you drag your plunger back out to here, then you're going to spread this volume out. And with this volume here being spread out, you're going to see your pressure actually decrease. Okay. Now, one thing that I want to tell you is that this is a closed system. Okay. Now, let's say that you were to chop this valve off and have an open tube. If you pull on this plunger suddenly, then you're going to see air come in here. And the reason why air comes here is because air flows from an area of higher to lower pressure. And so if you increase the volume here by pulling this plunger out, then you're going to decrease the pressure in that chamber and air will come in order to equalize. So again, gases, like liquids, which you saw in the circulatory system, they flow from high to low pressure. So pressure and volume turn out to be inversely related. When you increase volume, pressure goes down. When you decrease volume, pressure goes up. And this is something that you can see in this diagram. Okay, so the pressure of a gas in a closed container is going to be inversely proportional to the volume of the container. So in plain English, what that means is you make the container bigger, you get lower pressure, air comes in. You make the container smaller, you have a higher pressure, air goes out. So how do you get air in and out of the lungs? You make the thoracic cavity bigger or smaller. So let's take a look at what happens here. The first thing that we're going to take a look at is intrapulmonary pressure. So this is going to be this sort of pinkish line right here. And what I want you to notice is that when inspiration or inhalation occurs, you expand the thoracic cavity. When you expand the thoracic cavity, the pressure will drop. But when the pressure drops, air will come down the trachea into the lungs, and your pressure will come back up and equalize. And when you get full equalization, that is when the inspiration ends. Now, you've taken a breath in, you've expanded your chest cavity, and now the recoil and the surface tension, recoil of the lung tissue and the surface tension, are going to compress the lungs. So when the lungs get compressed, then the pressure inside the lungs is going to rise. Now it rises, and then air will move out of the lungs into the trachea, out of your mouth. And so when that equalizes, you're going to come back down again to zero or equilibrium. Now there's something that I want to point out here. Your pressure relative to the atmospheric pressure, look at this. You've got negative 2 millibars here. You've got positive 2 millibars here. And so your pressure changes about 1 millibar here and here. So it's very small pressure changes that actually drive inhalation and exhalation. So the next thing I want to look at in this diagram is intrapleural pressure. So I want you to notice that when your intrapulmonary pressure starts dropping, you have a corresponding drop in intrapleural pressure. Now you don't see a rise back up to equalization here, and the reason why is because your lungs are open to the outside, so air can move in and out of the lungs. Okay? Remember that the pleural cavities themselves are completely closed off, and that means they don't have any air that can come in and equalize. So there's going to be a lag. When you expand the chest cavity and you drop the pressure, the intrapleural pressure will drop along with it. When you expand the lungs and go back up, when you compress the lungs and the pressure goes back up, you're going to see this intrapleural pressure go back up as well. Now I want you to notice something else here, that the transpulmonary pressure stays fairly constant. So it's a little bit smaller here than it is here. Okay? But you can see that it always comes back to about a 4 millibar difference. Okay, so the third thing that we're going to look at in this diagram is the volume of breath. So as, again, look at the top portion here, as you carry out inspiration, pressure drops, then air, as the pressure drops, air will come in. Now it'll come in until you equalize pressure, and that's when breath stops coming in. Okay? When the lung tissue recoils, when that elastic lung tissue recoils and surface tension starts bringing those alveoli, starts compressing those alveoli, then you're going to raise the pressure in the lungs. Air is going to rush out, and so the volume starts reversing itself, and you exhale. And so during a quiet breathing, your normal amount of air that you take in and out during quiet breathing is about 0.5 liters of air. Okay, so again, during quiet inhalation, you're going to get contraction of the diaphragm. This contraction causes the diaphragm to flatten and descend. So this is going to be the area of the diaphragm right here. And as the diaphragm contracts, it's actually going to flatten out, which means it's going to be coming down in this direction, which is going to cause everything in here, all these cavities, to get bigger. So the volume is going to increase by about 500 mils, and therefore the pressure will decrease between 1 to 2 millibars. And so Because your intrapulmonary pressure or alveolar pressure has dropped to 758, the pressure is lower inside the lungs than the outside air, and therefore the air will flow to the lower pressure, in this case outside to in, and air will fill the lungs. And again, inspiration ends when you equalize, when that intrapulmonary pressure equals atmospheric pressure, which means it's going to be measured as 0. Okay, so your most important muscle in ventilation is the diaphragm, and so quiet inspiration fills the lung with about 500 cc's of air. Contraction of the diaphragm is responsible for about 75% of this air that enters during quiet breathing. Where do you get the other 25% from? Most of the other 25% comes from the external intercostal muscle. So I want you to notice the directions of the fibers here. These are going to pull the lungs or the ribs up and out and carry the chest cavity with it. And so when they contract, they're going to cause elevation of the ribs, because the origin point for these ribs, for these muscles, is going to be here and here. The insertion point is going to be here and here. And so as they compress, they're going to move in the direction of these arrows. So this is going to increase the anterior and posterior dimension of the chest wall and the lateral dimensions of the chest wall. And so the diaphragm kind of takes care of inferior and superior by flattening out. This takes care of the other dimensions, and this accounts for about 25% of quiet breathing, which is known as tidal volume. So here's what happens basically. In inspiration, your ribs get elevated, the diaphragm moves inferiorly, you get the contraction of external intercostals. And so basically the inspiratory muscles contract first, the diaphragm descends, the rib cage rises, the thoracic cavity volume increases. This causes the intrapulmonary volume to increase, which drops the intrapulmonary pressure, and then air flows down its pressure gradient from higher to lower pressure. Because it's lower inside the lungs, air comes in. Now let's take a look at expiration. Now, expiration in terms of quiet breathing is not an active process. Notice that you've got contraction of the diaphragm and contraction of the external intercostals in inspiration. In expiration or exhalation, the external intercostals relax, the diaphragm relaxes. And so what is it that is causing the compression of the chest cavity? Well, the rib cage descends because of recoil of the costal cartilages. And again, so remember that those costal cartilages are right here. So they've been stretched out a little bit and they're going to recoil a little bit. You're also going to get recoil of the lung tissue. And so because of all of these things, the thoracic cavity volume is going to decrease. Okay, the elastic lungs, these will recoil passively, and this causes intrapulmonary volume to decrease. When the intrapulmonary volume decreases, remember volume decreases, pressure rises. So you're going to raise your intrapulmonary or within the lungs pressure by 1 millibar. And this means that air, it's now a higher pressure inside the lungs than out, which means that air is going to move out of the lungs until you equalize at 0. Okay, so back to intrapleural pressure. This is below atmospheric pressure, and it's usually -4 compared to the intrapulmonary pressure. Now, this sort of vacuum holds the visceral and the parietal pleura together. And this means that they're going to move as a unit outward during inspiration and move as a unit inward during expiration. Okay? So as you inhale, the volume of this pulmonary space, this pleural space, increases. So intrapulmonary pressure will decrease. Intrapleural pressure will decrease. So with expiration, again, it's a passive process, no muscle contraction, due to the natural elastic recoil of the lungs and the chest wall. So I mentioned fibroblasts making elastic fibers So you can see the importance of this now, that it's very important for the lungs and the chest wall to be elastic. And so surface tension again also plays a role in exhalation. And this again is the reason why you don't want to have, or you don't want to get rid of surface tension. Okay, so the diaphragm and external intercostals will relax. The diaphragm will rise back to its original position. So it will rise from having been flattened out. Let me see if I can draw that. It'll rise from having been flattened out. It'll rise back up to its original position. The volume of the lungs will therefore decrease because you're making the space smaller. And again, decreased volume, increased pressure. Now it's greater than the atmospheric pressure and air moves out of the lungs. Okay, so let's talk about forced inhalation. So this is going to be inhalation sort of above and beyond normal quiet breathing. There are going to be a number of muscles that assist with that. So these are called the accessory muscles of inspiration. So one is the sternocleidomastoid, and the other are the scalenes. And the third is the pectoralis major. So where are these muscles? You see the sternocleidomastoid right here. You see the scalenes right here. And the pectoralis minor is deep to the pectoralis major. Okay, well, there's the highlighting. It's a little bit too late, unfortunately. Sternocleidomastoid, scalenes, and no pectoralis minor on the diagram. Okay, with forced exhalation, this is not a passive process because what you're trying to do is you're trying to move air out of the lungs faster for some sort of reason. And your most important muscles in forced exhalation are the abdominals because they will force, their compression will force the diaphragm superiorly. The other muscle group that's significant here is going to be the internal intercostals. And again, I want you to notice that these fibers are running in different directions. Now, with the internal intercostals, if you'll recall, the insertion is at this border of the ribs, and the origin is at this border of the ribs. The insertion is at this border of the ribs. So you're going to have this movement coming downwards like so, downwards like so. And this is going to act to compress the chest cavity pretty considerably. So again, remember that the internal intercostals are at a right angle to the external intercostals, so they pull things in a completely different direction to depress the ribs rather than expanding them. And so they're going to be antagonists, basically, to the external intercostals. Okay, so forceful exhalation and cough is going to be driven basically by two major muscles. They're going to be the abdominal, some of the abdominal muscles, and these are going to be the obliques and the transversus abdominis muscles. So basically what you're trying to do here, the reason why you're giving the elasticity of the lungs and the surface tension in assist is because you're trying to generate a greater degree of pressure in the lungs. So what you're trying to do is more quickly compress the intrapleural cavity or the intrapleural space, or the intraalveolar space. You're trying to compress the air, or they're trying to compress the lungs and raise the pressure quickly. When you raise the pressure quickly, then you move air out of the lungs more quickly, because with a larger pressure gradient, you get faster movement of the air. And so a cough is intended to dislodge something with basically wind pressure, or to push things out of your lungs using wind pressure or wind velocity. How do you generate a higher wind velocity? With a greater pressure gradient, and you're going to generate a greater pressure gradient by having this sudden and sharp contraction of the abdominal muscles. Now let's take a look at some of the measurements of ventilation here. So this is going to be a spirographic record for a male. So these are going to be average values for an adult male. So at this point, this portion sort of highlighted in the light blue, you'll notice that there's quiet breathing that goes on here and here. So you raise the amount of air within the lungs here, you depress the amount of air of lungs here, and that's going to be something that's called tidal volume, which is about 500 milliliters. Now you have an additional amount of air that you can breathe in, and this is called the inspiratory reserve volume. And so the tidal volume plus the inspiratory reserve volume together make up your inspiratory capacity. This is your expiratory reserve volume, this portion that dips down right here. So this is your expiratory reserve volume, and then down here in the green area, you've got residual volume. So residual volume is the volume of air that never leaves the lungs. And so this is something that I hope that makes sense. You're always going to want to have at least a little bit of air left over in the lungs, because if you got rid of all of the lungs, then the sides of your alveoli would stick together, and it would be really hard to open your lungs back up by breathing in. It would be really difficult to open up a collapsed lung, and that's the only condition under which your residual volume leaves, is if you have a collapsed lung. And so your expiratory reserve volume plus your inspiratory capacity, your expiratory reserve volume plus your residual volume give you your functional residual capacity. Your inspiratory capacity plus your functional residual capacity give you your vital capacity. So your vital capacity is basically maximum inhale followed by maximum exhale. So again, your vital capacity is going to be from here to here. So if you have a maximum inhalation right here, and then exhale as much as you can, that's your vital capacity, which is about 4,800 mils in the average male. Now, vital capacity can decrease as you age or with lung issues. So your total lung capacity, if you throw residual volume into this, is going to be about 6,000 mils. Okay, so if you'd like, you can pause the video here and take a look at these different respiratory reserves and volumes and capacities for males and females. And so the interesting thing about this is that it gives you the average adult male versus the average adult female average value. And to me, the really sort of interesting thing about this is that the tidal volume is about the same with everybody. But on average, men have a higher inspiratory reserve volume and men have a higher expiratory reserve volume. And I guess with a higher expiratory reserve volume, you could say that men are a little bit more of a blowhard. I know I'm not going to have any disagreement from my female students. Anyhow, enough puns. If you want to pause the video and take a look at this, then that might be a pretty good idea. Okay, now that you've moved on, this is another depiction of ventilation. So you can see where the inspiratory reserve volume is in pink. You can see where the tidal volume is in yellow. You can see where the expiratory reserve volume is in light blue. And again, you can see that the tidal volume plus the inspiratory reserve volume make your inspiratory capacity. You can see that expiratory reserve plus residual give you your functional residual capacity. You can see that your two reserve volumes plus your tidal volume give you your vital capacity, and everything all together gives you your total lung capacity. And to be honest, I probably should have used this diagram to begin with. Okay, so there is something else called anatomic dead space, and this is the volume of air that is in the conducting zone and isn't available for gas exchange. So this is something that is different from residual volume. So residual volume is air that has reached the lungs. Okay, so this is the picture that I want you to get with anatomic dead space. As you inhale, air is going to move its way into the lungs, right? But as air moves in, when you have equalization, some air will be in these airways and will not have made it all the way in to the respiratory tissue. And so the air that's here is called anatomic dead space. This is about 30% of your... Okay, I think I moved the slide ahead a little bit too fast. Let me sort of repeat that anatomic dead space makes up about 30% of your total tidal volume. So let's talk about factors that play into the amount of ventilation that you can carry out. One is the pressure differences that you're able to generate. And remember that air moves from areas of high to low pressure. So the amount of surface tension in the lungs can keep you from being able to generate pressure differences. So there's something that's called compliance of the lungs, which we'll get into just a little bit. And there's something that's also called airway resistance. So these different factors play a role in how well that you can carry out ventilation. Okay, so let's talk about surface tension first. Now remember that the alveoli are coated by alveolar fluid, and this is mostly water. This does create surface tension. And as I said before, water molecules get strongly attracted to one another. And again, what surface tension will tend to do is to collapse alveoli inward. Now, this is great during exhalation because it contributes to the normal recoil of the lungs. But if you don't have enough surfactant and the surface tension is too high, too much surface tension can collapse the alveoli. So the surfactant that's produced by type 2 pneumocytes or alveolar cells, this decreases your surface tension to a physiologic level. So actually, surface tension in this case is actually a homeostatic variable. Okay, so I wanted to show you this with just the lung here, and this is a lung that's actually being kept alive for a lung transplant. So there's something called compliance, which is the degree of stretchiness of the lungs. And so the degree of stretchiness of the lungs kind of determines how much effort is required to stretch out the lungs and the chest wall. So compliance is a measure of how much your lung volume changes with a certain change in transpulmonary pressure. This gets determined by the distensibility of the lung tissue, so how much can it stretch out, and by alveolar surface tension. So the makeup of your lung tissue and how much surface tension is there, these play into compliance. Okay, so a high compliance means that the lungs and the chest wall are easy to expand. Low or poor compliance means that the lungs and the chest wall are difficult to expand. There can be a number of different things that are responsible for this. Chronic inflammation can result in low compliance. So can fibrosis, which is the formation of at least a little bit of scar tissue. Extensive scar tissue formation, of course, can make the lungs and chest difficult to expand. If you have inadequate surfactant production, as happens in premature babies, then this can also result in low or poor compliance. Finally, fluid and the alveoli. If you have pulmonary edema, if you have fluid that accumulates actually within the alveoli, more fluid means more surface tension. And so this is going to result in low or poor compliance. And this is one of the ways that pneumonia can make your life really difficult. Okay. Another factor is called airway resistance. And so resistance is basically the friction of the air against the airways. And so we talked about resistance with the circulatory system. This is the exact same thing, except you're just talking about air instead of liquid. So your airflow is directly proportional to the difference between the pressure difference between the atmosphere and the alveoli. Now, very small changes in pressure, as we saw, 1 or 2 millibars, result in large changes of the volume of gas flow. So 1 to 2 millibars results in the movement of 500 mils of air. Now, what this means is that because resistance is inversely proportional to airway diameter, this means a large diameter airway has less resistance to airflow than a small diameter airway. This means that smooth muscle contraction results in bronchoconstriction, therefore a smaller diameter, therefore increased airway resistance. So the resistance is increased to the 4th power of the degree of the compression of the airways. So again, this is very similar to blood vessel vasoconstriction. Now the problem here is that resistance can result in small changes in pressure. But since air moves in and out of the lungs itself with small changes in pressure, when you start messing with that, then you can really affect how easy it is to breathe. So your greatest resistance to flow occurs at medium-sized bronchi. So you see it at the top of this curve right here, the amount of resistance. Now, why don't you get resistance at the trachea? Because the tube's really big, minimal resistance. Why don't you get resistance at the terminal bronchioles? They're really small, but there are so many of them that their total cross-section is really big, and that reduces resistance. Now, once you're at the terminal bronchioles, gas flow is going to stop and diffusion is going to take over in the respiratory portion. So when you're talking about ventilation, airflow is going to go into the terminal bronchioles, so it is changes in total pressure that get you from outside to inside. Okay. So if we look at smooth muscle constriction in airways, you can see the bronchoconstriction at the bottom portion here. This is going to increase resistance. And what are things that can increase resistance? Irritants. So you may have noticed if you go into a room that has got really strong fumes, it becomes harder to breathe. It's because you're getting a bronchoconstriction to try to protect your respiratory surfaces, and with that resistance, it becomes harder to breathe. Also, maybe if you've ever been around a campfire, and if you've been around a campfire and smoke blows towards you, they say that smoke follows beauty, so I'm constantly getting smoked by campfires. You know I'm joking there. But the smoke is an irritant. So this is the reason why when that campfire smoke washes over you, you find it harder to breathe. It's because you have bronchoconstriction due to the irritants. Asthma can cause increased resistance. Now, when smooth muscle relaxes in airways, then you're going to have bronchodilation. This is going to decrease resistance. And so sympathetic nervous system innervation results in bronchodilation. In other words, epinephrine. This is the reason why you give somebody an EpiPen who is an asthmatic. So the smooth muscle in the bronchioles has beta-2 adrenergic receptors. And so these are going to be inhibitory receptors that inhibit the constriction of the smooth muscle.